Okay, Chapter 20 is about maintaining skin integrity. So it is your responsibility to observe your client's skin every time you give them care. So if you are turning them every 2 hours, you need to look at their skin every 2 hours. Anytime you do anything to the resident, just look and see if you observe any problems with their skin. Patients who have more problems with their skin are the ones that are going to be immobile. If they're not able to move around, we're going to talk about pressure sores, pressure ulcers. Those people are going to be staying in one position for too long, and they're not going to get circulation to the area. So their skin may start breaking down because of immobility. Immobility is a huge risk factor. So even if the patient cannot move themselves, you're going to be doing range of motion on them once a day, but you also need to be turning them every 2 hours and checking their skin condition. Residents that have reduced cognitive abilities, maybe they don't know that they injured themselves or that they got a bruise or that they have some problem with their skin. They don't put 2 and 2 together with that. They need to have help with keeping up with their skin. And then just the natural aging process. As we age, we talked about our skin is going to wrinkle. It's also going to start getting thinner because that third layer of subcutaneous fat is less and less, so the skin gets less pliable and more like paper thin, and it'll tear easily, and we'll talk more about those. But positioning your residents correctly helps prevent their skin breakdown. It also maintains the function of the joints and muscles, and it increases their comfort. So we already talked a lot about turning, repositioning, maintaining good muscle alignment, bone alignment, but it also is going to help prevent their skin breakdown. Keys to maintain your skin integrity is promoting good circulation. Moving your resident around promotes that good circulation to their skin. Even if they are in a wheelchair, you still need to get them to stand up, weight shift, toilet them, get them moving at least every 2 hours so that they're not just sitting in one position. Good nutrition helps with your skin. So we have to make sure the residents are eating well and drinking well. They have to have adequate amount of fluid and water and hydration to keep their skin hydrated. They also need more protein in order to help their skin or wounds to heal. Observing your skin, inspecting it daily, each time you're turning the resident, doing your range of motion, all of these things are going to help with skin integrity. Toileting your person, making sure that the incontinent people are changed every 2 hours. If you leave too much moisture on the skin, it's going to cause skin breakdown. When you're bathing your person, you're making sure that you're keeping the skin clean and dry. Now, if you're giving a person a bath or a shower and you notice something wrong with their skin, you don't report it right away to the nurse, as long as they're not bleeding. You just finish up with what you're doing. You don't rub over reddened areas. And then once you get the person dressed and warm and appropriate, then you write out on a skin sheet, an assessment sheet, or a report sheet, and put it on there and then give it to the nurse. The nurse doesn't need to come in the middle of a bath and see the skin breakdown, but you do need to report it to her. So that you don't need to leave the resident alone in the shower, or you don't need to leave them uncovered while you go try to find a nurse to show them the skin breakdown. If you see bandages or wounds that need to have a dressing changed on them, just reinforce it as best you can, get the person comfortable, finish up your bath, and then go get the nurse and let them know it needs to be changed. When you are changing briefs and incontinence attends, you may come across some dressings that are loose or coming off. Then you finish up with what you're doing, reinforce it as best you can, and then go get the nurse. Reporting immediately any skin changes in color, skin condition. Reporting it immediately means that you are finishing up with what you're doing with the resident, and then you're going to go let the nurse know. Okay, don't leave the person uncovered while you go let the nurse know. This is what a skin bath assessment sheet looks like in one of the areas we used to go to clinical. The CNAs would just have to circle any areas of concern. If they see a skin tear, a bruise, a discoloration, if they have problems with their toenails, if they have problems with their scalp, like we talked about with shampooing, if they have a rash somewhere on their body, if their eyes are reddened or they're noticing any drainage from their eyes, if their fingernails have some problems with them. So anything on this person, you would just circle the area, Write your location, describe it just a little bit, and then sign it, and then give it to your nurse so that we know it was reported immediately. Okay. And then the wound care nurse will go back with the nurse, or the nurse needs to go assess it, and then they come up with a care plan with how we're going to take care of it. Okay. Back rubs, usually done as part of HS care or hour of sleep care, but a back rub is done to improve circulation. We need to make sure that this person has nothing stuck to their back or stuck to their skin before they go to sleep for the night. It's done in an upward motion. It only lasts about 2 to 3 minutes. You're not rubbing on them for half an hour for a massage. But don't rub over any red or bony areas. If they have a lot of reddened areas or bony areas sticking out, do not rub on top of them. Also, don't rub where there's any skin irritation or skin breakdown. Make sure you're wearing gloves. If they have any rash on them, don't rub on that rash area. You can knead your fingers on their skin. Kneading is just like you're rolling dough. You're using your thumb and your fingers to just roll around on your skin. You're not just using light touch on their back to do a back rub. You're actually using some gentle grasping motions or long strokes up and down your back, and we're going to practice doing that. But know that it is done as part of PM care to help improve that circulation, also to inspect their back and their skin for any issues or concerns. Okay. Your anti-embolic stockings, or your TED hose, or your pressure stockings. We're going to learn how to put them on. We're actually going to practice putting them on Susie, but you may need to put these on residents. Some of them are only knee highs, some of them are thigh highs. They come in packages. They're measured by the nurse for which size they need to wear. The tip of the toe is open and it has a little color on it, and that tells you what size the stocking is. You leave the stockings on for about 8 hours, but you have to take them off at least twice a day. So every 8 hours, we need to take them off, inspect the skin underneath, and then put them back on. And we're going to practice putting these stockings on and off, but these elastic stockings help to exert pressure on their veins to help improve circulation. They promote venous blood return back to the heart. They're especially useful in people who have had surgery, or people who have heart problems, or people who are not mobile or immobile. They help prevent blood clots because they're improving the circulation of the venous blood back into the heart, instead of the blood just pooling in their legs and clotting. The client has to be laying supine when you put the stocking on. So if they are sitting up in the wheelchair, you need to lay them back in the bed and lay them supine to put the stockings on. Make sure there are no twists or wrinkles in the stockings because they will cut off the circulation in the area that you have the twist or the wrinkle, and then they're going to cause skin breakdown. Everybody's worn some pantyhose or put something on you, some tight-fitting socks, that if you leave the little band, like some socks that have the elastic bands on the top, by the end of the day, when you take your socks off, you have an impression around your ankle where that sock has been. So you need to make sure that you're putting them on, that they're the correct size, that the nurse has measured, and there's no twists or wrinkles. You also leave the toe open at the end so that we can pull it down and make sure at that distal end that they still have good circulation. Their toes aren't turning purple because the stockings are too tight. We use that to feel for their pulses. So that little toe area is at the bottom of their foot, and then you've pulled it up all the way. You don't fold the stockings over on top of each other. They should be the right length where they go all the way up and straight and smooth on their skin. And we're going to practice putting these TED hose or compression stockings on each other and on Susie. A sequential compression device. A lot of times you'll see these in the hospitals, long-term care areas. If they're in rehab, they really don't have them as much. But if you have some bedridden people in nursing homes or skilled nursing facilities, they may have their TED hose on, and then on top of the TED hose, you're putting these compression devices. These are little pillows that blow up, so they Velcro onto the calves of your person, and then they plug in with a plug to a machine that hangs off the end of the bed that provides a pump for air and compression through these. They also help to prevent blood clots. They improve circulation. When you are getting your person up out of the bed, you're supposed to unvelcro them and take them off. You don't just disconnect them from the end of the tubing and let the person walk around with these things attached to the bottom of their legs. Unvelcro them, put them back on when they get back in the bed. They're inside of the cuffs. It's labeled where their ankle should be. It goes from their ankle to their knee a lot of times, just right around their shin. And then plug it in. Make sure the machine is turned on. You'll hear it pumping up and deflating and inflating with air. It means it's working. Okay, if you have any issues, just let the nurse know. Observing and reporting for your skin conditions. Residents who are immobile and residents who are very thin are more susceptible to having problems with their skin. Also, residents who aren't eating, getting good hydration, residents who aren't drinking, those kind of residents need to be watched more closely. Residents who cannot move need to be motivated to move or need to have range of motion and turning every 2 hours. If your resident is cognitively impaired or they can't communicate well, they may not know that they need to move. You need to make sure you're encouraging them and helping them move. Pressure ulcers or decubitus ulcers or pressure sores are breakdown of the skin. Just because it's called a pressure sore doesn't mean it's only caused by pressure. There are many reasons why we get tears in the skin, breakdown in their skin, and all of these reasons can be prevented. If we are turning our person and improving circulation, if we are looking for reddened areas before they get worse, if we are inspecting skin every 2 hours, we can prevent some of these decubitus ulcers or pressure sores. But these pressure sores can be caused by pressure. They can also be caused by friction and shearing. So this is the reason we're not just yanking the sheets out from underneath them. We're actually rolling the sheet up and then rolling the person on the other side and unrolling the sheet. You don't just pull the sheets out from under them because you could cause carpet burn or shearing or friction. Also, when you're taking them off the bedpan, we talked about putting a little bit of powder on the bedpan so that that plastic isn't stuck to their skin and then you rip it off and it shears off their skin. When you're taking off a Band-Aid, a lot of times you pull off some of their skin with their Band-Aid or with their tape. So there's plenty of reasons why we are going to have a break in the skin, and then poor circulation, poor nutrition, poor wound healing is going to cause it to turn into a pressure ulcer or a decubitus ulcer. It'll go through all 3 layers of skin if we don't watch it and keep it safe. So if we start having any kind of discoloration, that's the stage 1 pressure ulcer that we talked about, that discoloration needs to be reported to the nurse so that we can check it out. Too much moisture can cause decubitus ulcers. So a lot of patients in their perineal area, if we're leaving on wet briefs for too long, or if we're putting excessive lotion on someone and there's too much moisture. If you put too much moisture on their feet or on their hands, and then they just break down from their skin getting wrinkled with moisture. Wrinkles in the sheets can cause pressure ulcers. So pressure ulcers are definitely easier to prevent than they are to treat. We just need to make sure we're inspecting their skin every 2 hours. This is a decubitus ulcer on someone's heel. So something had started it and it just kept on going deeper and deeper and deeper. The most common cause of pressure ulcers is pressure. But pressure over time is going to decrease your circulation. Once this area of circulation is decreased, then you're not getting the proper nutrition to the area. The red blood cells aren't able to carry oxygen to the area. The cells start to die and then an open wound is forming. That occurs most often where your skin is thin and where you have a bone underneath. So in your book, you have some pictures of decubitus ulcer pressure points. These are areas that we know have bony prominences sticking out that could possibly have more susceptible of an area for a pressure sore. So on the person's heels, a lot of times we'll tell you to float their heels off the bed, which means you're putting a pillow underneath their ankles so that the heel isn't touching the bottom of the bed. We're also going to talk about a bed cradle, which is a piece of metal bar that comes up off the edge of their bed and over top that we can drape their sheets over top so that the sheets aren't pushing down on top of their toes or on top of their feet. or that their sheets aren't touching their skin and causing skin breakdown or pressure ulcers. When we roll the person on the side and do the lateral position, we talked about that, making sure that they're not laying on their arm. We have a pillow under their head. We have a pillow under this elbow to make sure that, in this wrist, because those are areas of pressure ulcers. The hip is a pressure ulcer area. The knees are a pressure ulcer area. And when your knees come together and when your ankles come together are areas of possible pressure points. So we put a pillow in between their knee and their ankle to provide cushioning for those pressure point areas. When your resident is sitting up in a wheelchair, they have a pressure point right here on their shoulder blade, on their buttocks, or on their coccyx bone, their tailbone sticking out. Their heels and the ball of their feet from being on those hard plastic footrests all day. When you lay someone on their side again, their ear could be a pressure point. Their shoulder, their hip, their knees, their ankles. Anywhere where these bones are sticking out, we have less fat and we have thin skin. We can definitely cause a decubitus ulcer. So the layers of the skin we already talked about in the anatomy chapter with the 3 layers of the skin. There are 3 stages of pressure. There's 4 stages of pressure ulcers, but the first 3 stages are the first 3 stages of skin. So a stage 1 pressure ulcer is the top layer of skin, or the epidermis. Anytime you see reddened or discolored area that does not blanch or does not go away when you touch it. Blanching means when you press on the area, it turns white, and when you let it go, the color comes back to it. If you press on an area and it doesn't turn white or it doesn't blanch, that means there's no circulation to that area and it's already started to become a stage 1 pressure ulcer. A stage 2 pressure ulcer is when the top layer of skin, the epidermis, is gone and it's more like a blister. So now you can see the second layer of skin. Everybody's had a blister. You know, if you get a blister wet, it burns, it stings, it hurts, because in that second layer of skin, you have your nerve endings and your nerve fibers. When you get a paper cut, you barely just cut through that top layer of skin. You're in that second layer of skin. That's called a partial thickness skin loss, where you're in that area where the nerves are, and it's a little bit painful. So it looks like a pop blister or an abrasion or a shearing, or you've sheared off your top layer of skin. Okay. The third layer of skin is a full thickness skin loss. So when you're down to that third layer of skin, then you're in the fatty layer or your subcutaneous tissue. You can start seeing little fat tissue like whitish or yellowish kind of strandy looking material or cushiony looking spongy material. It also looks like a deep crater because you can see through those first 2 layers of skin and it starts to form a crater. Once you've gone through all 3 layers of skin, your stage 4 pressure ulcers are down through the fat and the muscle and even can tunnel down to the bone. So this tunneling needs to be packed. Pressure ulcers have to heal from the inside out. We can't sew them back together and they heal. That top layer of skin is gone, the second layer of skin is gone, the third layer of subcutaneous fat is gone, and now it's tunneling down through fat and tissues and muscles and bones. But it has to be packed, and it could take 6 months to a year for it to heal from the inside out. We are going to keep it covered with gauze dressings that the nurses change once a day. But like I said, if you are changing their briefs, or if you have it down here in the coccyx area, and it just gets dirty, it gets urine on it, it gets stool on it, you need to let the nurse know so that we can change it. Because if that dressing stays moist or it has some kind of contamination on it, it's going to infect the wound that's underneath it. Treatment and prevention, promoting your circulation, again with turning your person every 2 hours, at least every 2 hours. If the nurse wants you to turn them every hour, you just ask for help. And then you make sure they get turned at least every hour. Passive range of motion, active range of motion, encouraging the resident to move around. Active range of motion means the resident can do it themselves. Passive range of motion, you are actually moving these extremities for them. And we've gone over and over about why moving and repositioning and comfort measures are important. It's important for skin conditions. It's also important to prevent contractures. Some residents have cushions on their bed. The cushions help relieve pressure. Some residents have special mattresses called Clintron beds. They don't usually use water beds anymore, but these are air mattresses. So make sure that the air mattress is plugged into the red outlet on the wall so that if the power goes out, the mattress still stays blown up. You plug these into the red outlet. They blow up the mattresses that are in the bed. They are set to different pressures. Some of them turn the patient from side to side. Some of them blow up and deflate and blow up and deflate, just like the sequential compression devices for their legs. But it helps relieve pressure on different areas. It helps for pressure ulcers to heal. Sometimes if people have pressure ulcers on their back, you want to keep them off their back as much as possible. But even if you just keep turning them from side to side to side, they still need some extra help with a pressure relief mattress. Wheelchair cushions. Some residents need a wheelchair cushion in their wheelchairs. If they need to sit up into the wheelchair, make sure their cushion is in there first before they sit on it. And even your wheelchair patients, again, get them up, get them standing, get them toileting, get them moving around and weight shifting every 2 hours so they're not just sitting on their coccyx bone all day long. Pillows, using them under their heels, floating their heels off the bed, using them on their elbows to keep the elbows from rubbing against the bed. There are special heel protectors, and we're going to show you some of these. These little boots, they're not restraints, but they go on the foot. They help with foot drop, but they also help to prevent the heel from rubbing on the bed, or they cushion the heel for the person. They also have those for the elbows. But make sure you're always putting those cushion devices. This is what your bed cradle looks like. It's like a metal bar that comes up, and it holds the sheets from touching the person's skin. Maybe they have ulcers on their skin, or it helps relieve pressure from having too many blankets and too much weight weighing down on their feet and then pushing their heels into their bed. So your bed cradle is important to make sure that we're getting if they have skin breakdown or to prevent skin breakdown. Another thing to think about with preventing skin breakdown is always keeping your skin folds clean and dry. If somebody has some obesity or they have some skin folds, make sure you're lifting them up, cleaning up under there, drying it well before you lift the fold back down. Preventing friction, avoid rubbing, avoid dragging. Don't drag them on their bed sheets when you're trying to pull them up to the top of the bed. Don't drag the bed sheets from underneath them and friction and pull off their skin. Keep your bed clean. Keep it free of crumbs. Keep it free of wrinkles. All of that is going to help prevent skin breakdown. If you are allowed to use cornstarch or powder or baby powder in the bed, you're only supposed to use a small amount. Most places don't let you use powder anymore because it's a respiratory hazard. People were like covering the whole bed in powder, and every time the person moved, they're breathing in powder into their lungs. But this cornstarch or powder, it can help prevent you from sticking to your bedpan, or it can help you from sticking to your toilet seat, but you're just using a small amount. You're also not allowed to put these plastic pads directly in contact with the person's skin. The pads now feel a little bit more cloth-like. They're a little less plasticky, but you're still supposed to have a sheet or some kind of cloth between this plastic pad and the patient's skin. Same thing with their briefs. If their briefs are made out of plastic, you need to make sure you're changing them every 2 hours. Try not to elevate the head of the bed higher than 30 degrees because it puts a lot of pressure on their hips. When they're sitting in that position for too long, there actually could cause hip breakdown. They'll be sliding in the bed if you don't raise the feet up at least 15 degrees. And then when you do that, it makes them like a V in the bed where all of their pressure is on their hips and their buttocks or their coccyx bone, which is going to cause pressure ulcers on their coccyx bone. Promoting good nutrition, making sure they're getting good fluid, making sure they're getting good nutrition. They're eating their most nutritious part of their meal first, and they're eating a lot of protein and a variety of meals, a variety of foods to get all of the nutrients that they need. Accurate weights. Make sure we're recording the weight at the same time every day. So we talked about this in the vital sign chapter. When we're trending weights, we need to make sure that the resident goes to the bathroom before we weigh them. We also are making sure that they are, per facility policy, if they need shoes on, you put the shoes on when you weigh them. If they don't have shoes on, you take the shoes off. But weight is the most important factor in nutritional status. We can tell if people are losing weight, and the more thin that they get, the more malnourished that they get, the more susceptible they are to having skin issues and skin breakdown and decubitus ulcers. You'll be following the nurses around, the CNAs around at clinical. If you see any of these skin conditions, we'll all go in and look, or we'll look at it. Again, if you see something falling off a resident as far as a dressing, reinforce it as best you can, then let the nurse know. The wound care nurses come around every day. They change those dressings every day. They also change some PRN. So if they need to be changed more than once a day because they fell off, we're going to do that. But we need to be careful with how much tape we put on the patient's skin. A lot of these dressings are made out of Tegaderm, or they're like a special kind of paper tape so that they're not too rough on their skin. So skin conditions, make sure you are observing and reporting. Make sure you're using pillows. Make sure you're using the cushions. If the resident is supposed to be using a cushion, you need to make sure that they have their cushion. And you need to make sure that all of their sheets are free of creases, free of wrinkles, free of crumbs, free of anything that's going to cause or could contribute to their skin breakdown.